Hello, everybody. We're going to get started for our first set of rounds for the 2023-2024 year. Today we have Lisa Ivany from Lindsay Stevenato's clinic in Parry Sound, and I will let her introduce herself.
Thanks, Kathy. So today I am going to be discussing physiotherapy and autism spectrum disorder, or ASD. We're going to get right into it. My presentation style is very informal, so I would much rather have a conversation than a presentation. So you guys all come to this with your own level of knowledge and expertise. So feel free to jump in with any questions, comments, or anything that you're seeing clinically that's different from what I'm seeing. All right. I was able to advance this and now I'm not. Oh, there we go. Okay. So just before we start, I am an independent contractor. I provide pediatric physiotherapy and psychotherapy services to a for-profit children's therapy provider, and that's Lindsay Stephanato Children's Therapy Services, and I am receiving an honorarium today. So this is me. I have been practicing pediatric physiotherapy for 26 years, since 1997, when I graduated from the University of Toronto. I was lucky enough to have some wonderful mentors at the Hospital for Sick Children, which is where I started my career. And I moved to Parry Sound in 2000, 23 years ago. About 2.5, 3 years ago, I actually started a master's in counseling psychology. So for a number of years, I've been noticing a strong correlation between developmental trajectory of infants and children and maternal mental health, specifically seeing a lot of children with plagiocephaly or flat skulls, whose names I saw again in junior kindergarten school entry with emotional regulation, dysregulation issues. So I felt like I needed to bring a more holistic approach to my practice. So am doing more mental health work with the physical health work. The body and brain are intricately connected, and I'm hoping to treat my clients in a more holistic manner. Okay, so talking about what our goals are to hit today. So we're hoping to understand the basis of movement disorders in children with ASD and understand some of the things that we're seeing at very early ages in terms of movement. Understand some of the risks and complications associated with toe walking and some of the ways physiotherapists can intervene. Help identify when we can refer children with ASD or any children to a pediatric physiotherapist. And then we're going to look very briefly at the end. We're going to talk about the 3 different levels of autism spectrum disorder and how physiotherapy can assist moving forward. If there's anything else that I'm not hitting that you guys would like to, please let me know and we'll try to do so. Okay, so this comes from a very interesting study that was done in 1998. It's a dated study, and we're going to build on the information that Titelbaum and his colleagues came up with. But basically, they took 70 children with confirmed diagnosis of ASD, and using home videos from their infancy and early infancy, looked at commonalities in movement. And these are some of the commonalities that they saw in children with ASD in the infant stage. And one of them was the persistent asymmetry. We're going to talk a little bit more about the asymmetry. So in other words, we're not seeing the same things happen on the left and right side of the bodies. And we were seeing this asymmetry in all positions, in prone, in sitting, in crawling, and even in walking. So the asymmetry was a big one. So for example, in crawling, sometimes I'll see kids demonstrate what I call a tripod crawl. So one knee is down and one foot is down. Even if they're bum scooting, one kind of foot and leg is flexed in under them and one leg is extended out in front of them. So we see some significant asymmetries there. Impairment in head and body righting reactions and rolling. And this is one that I see clinically a ton. I call these babies my non-rollers. In other words, they're hesitant to roll, they don't roll. And when and if they do, it's a very log-like roll, so not segmental. There's no rotation of the trunk. None of that head comes first, trunk follows. It's a log roll. We also see difficulty weight bearing on the extended arms in crawling. And this is a big one, and it translates to lack of crawling in many instances. And we'll talk a little bit about more crawling in a few slides. And then we see challenges in the development of gait later on down the road. Again, they keep their arms in that high guard position for longer. We see a prolonged foot flat stage in their gait, and not that heel toe pattern that we're used to seeing. And sometimes we think, is this their need for more proprioceptive input? So they're slapping the foot down to get that proprioceptive input. And then we also see a delayed weight shift of the trunk during the swing phase. We'll talk about this a little more as well. So when kids get up on their feet and walk, it's a lateral movement. You know, they weight shift from the left side to the right side, left side to the right side. In ASD, it's very much an anterior posterior movement where we don't see that lateral weight shift. So that was Teitelbaum's work in 1998. And then Esposito and his colleagues built on this in 2009. And they found as well, go back to the symmetry, a significant decrease in symmetry in standing and dynamic postures, even when compared to those with developmental delay. So even children who are demonstrating just delay, not ASD, they have more symmetry in their movement. The skills are just delayed. We do need to be careful when we're looking at asymmetry, that we don't judge too harshly in the 0 to 3 month range. So for example, in the picture, we see the babe is demonstrating the ATNR, the asymmetric tonic neck reflex. You know, the rotated side has the extended arm, the skull side has the flexed arm, obviously in asymmetry. But with the ATNR, this is normal, this is typical. The other thing we want to watch for in those early months are hemiplegia. So asymmetry could also be a sign of that. So we don't want to, you know, jump on things if we see an asymmetry. And as the last point indicates, it's not a one and done assessment. We need to track these children over a period of time. So every time they come in for their well baby visit, you know, are things improving? Are we still seeing that asymmetry? Is the asymmetry, you know, improving? Are they using both sides of the body appropriately? You know, what the other thing that we see a lot in terms of asymmetry is torticollis, and it's another example of asymmetry. But again, what's causing it? Is it a true asymmetry? Is how the parents have set up the environment, so the child is always looking to one side to look in the direction of the door when they're in their crib or in their car seat, looking out the window. So it's not a one and done. It's something we look at on a regular basis. Okay, the other thing that we can look really closely at, and we are seeing differences in our children with autism spectrum disorder, is pull to sit at 4 months of age. And this is a part of the assessment I administer, and we'll talk a bit about the assessment that I administer, but it's called the AIMS, or the Alberta Infant Motor Scale. And we do a pull to sit in early infancy to see where the babe's head leg is at specifically. So are they developing those neck flexor muscles? Are they developing that anterior head righting? And there is a notice, or it's been demonstrated that children with autism spectrum disorder, or at an elevated likelihood, so these are children of siblings potentially, they are going to have a more delayed head leg than our neurotypical developing children. There's also a strong correlation between delayed or difficulty with pull to sit and social communication skills. And this makes sense if we think about the muscles that are required for pull to sit, you know, head, neck, trunk, arms, hands. These are the muscles that we need for social communication. These are also play a role in pull to sit. So there is a correlation starting to be noticed with this milestone as well. So it's another one to have a look at the 4 month stage. How are they doing with their pull to sit? Are they really far behind? Are they getting it? And again, we're not going to make a diagnosis based on how their pull to sit is, but it's just another clue in the back of our head that maybe we need to refer to somebody, or maybe we need to keep a closer eye on this little one. Oops. Trying to advance. There we go. Crawling. So we had talked about crawling before, in that children with ASD have greater difficulty weight bearing on their extended arms. And, Levine and Collett had demonstrated in 2021 that children with ASD are 25% less likely than neurotypical children to crawl in 4-point. And I do see a lot of non-crawlers, what I call my bum shufflers, in the clinic. They don't all have ASD, but there is a portion of them that do. And a lot of people ask, well, what's the big deal? They're moving around their environment. It is a bit of a big deal. Crawling is a very important motor skill. It increases connectivity between the left and right side of the brain. It tells us that babe does have communication, very well communication between the left side of the brain. It gives us information about quality of movement. It's very important for strengthening of the trunk as well as the shoulder girdles. Studies have demonstrated that children that don't crawl have delayed fine motor skills as they hit school. This is because if we don't have proximal muscle strength up at the shoulder girdle, we can't have distal control. Development happens proximally to distally, so we need the strength and stability at the shoulder, the elbow, the wrist before we can expect our children to have that distal fine motor control. So crawling is an incredibly important skill. So it is concerning that our children with ASD are doing less crawling, if they crawl at all. We also see difficulty with what I call the more mature, more complex motor skills that involve rotation specifically. So these kids prefer to move in one plane, and that is the anterior posterior. They tend to move in this plane. They don't even have a lot of movement laterally in that frontal plane. And in terms of rotational movements, that's a far more complex movement for them, and we see less of it. So those rotational movements are required for their transitions, required for rolling, required to move from lying to sitting. And these are the babes. They'll try to do this, and they'll try to do it via a sit-up. Again, that anterior posterior movement, as opposed to rotating, pushing up from the floor, and getting up to sitting. Even pulling to standing is something that they will avoid doing it in a more mature way. So again, when we look at pull to stand for our neurotypical children, we're looking at, they move from tall kneel to half kneel, 1 foot up, 1 knee down, pushing up through that flex knee up into an extended standing position. Our ASD kids often will try and grab whatever it is they're reaching and pull themselves up with both legs extending at the same time. Again, moving in a very anterior posterior direction and not having any of that lateral weight shift or dissociation of movement between the left and the right side of the body. So it's really where quality of movement changes significantly. I just noticed something in the chat. Oh, okay, good. It wasn't for me. So yes, please interrupt. Thank you, Kelly, for putting that out there. Like I said, I'm a very informal presenter, so I'd rather have a conversation. So jump in anytime, anyone, seriously. Okay, keep doing that. Advancing the slide. Okay. So challenges in upright. We talked about, lack of complex movements. We've talked about lack of rotation. We've talked about a tendency to move in the anterior posterior plane as opposed to the lateral plane. And we see all of these things translate into standing as well. So children with autism spectrum disorder, and it's interesting, right? Because often parents bring the kids to me. They just want them to walk. They just want them to get them upright. Their goal is independent gait. And once they have that, okay, thanks, Lisa, we're good, we're done. We just want them walking, which is disappointing because there's so much more to it than just getting them up and walking. And it's very much about quality and how are they walking. And it gives us a lot of information. So children with ASD, they demonstrate less stability in standing. They're not as stable on their feet. So they'll use a wider base of support. For example, they'll stay externally rotated for longer periods of time. They have, again, that lack of lateral postural sway. So when these kids start walking, they're using momentum. They're falling forward, basically. So it's an anterior posterior movement, but not a weight shift with control from left to right. They have increased difficulty with postural control, correlated with more severe and repetitive movement patterns. And we see this, and we're aware of what these movement patterns are. So we also see a lot of core weakness. Again, think about it. They didn't rotate, right? These are the kids that often didn't crawl. So they're not giving themselves as much of an opportunity for core strengthening. And so we see core weakness, and that core weakness impacts their stability and upright. I explain to parents that the core is the foundation of our bodies. The core is the structure, the foundation off of which our head, our arms, our legs move. So if the core isn't stable, the quality of our movement at our extremities is impacted. So I'm often bringing families and children back to the core. How's their core? How's our core? And often our core is not good. And we're going to talk a little bit about the implications of that moving forward. And again, if you think about our children, even our neurotypical children and their lifestyles today versus their lifestyles 20, 30, 40 years ago, these children are much more sedentary. These children are on screens much sooner. These children are seated for longer periods of time, whether it's a car seat, a booster seat, a bumbo seat. There's a million seating options out there. But they're not spending as much time on the floor, moving their bodies through space. They're not spending as much time on playgrounds. So there's lots of reasons why our children today are more at risk for core weakness than they were just a few decades ago. So what do I do? Physiotherapy intervention in infancy. I am a big proponent of early intervention. I feel like we can do so much more if we see our children earlier in their developmental course as opposed to waiting. So yeah, refer as soon as you notice something that's consistently concerning to you. I use, when we talked about this, the Alberta Infant Motor Scale as my screening tool. It is a screen. It's not a standardized assessment, but it gives us an idea of how that child is performing in their developmental skills when compared to age-matched peers. The AIMS is also nice in that it does look at quality of movement. It does look at rotation. It does look at, are they doing it on the left and right side of the body? So it's a great little tool that we can tell parents how their children are doing. I use neurodevelopmental techniques. So NDT is basically a manner in which we teach parents how to facilitate normal movement patterns. So when our child doesn't want to roll in a segmental fashion, we're going to facilitate that roll, and we're going to facilitate it a gajillion times a day. Because the more we facilitate it, the more we're creating those pathways in the brain, and we're hardwiring those babies to have those motor pathways. So we do a lot of NDT and teaching parents how to do the facilitations. It's not enough for them to bring them to see me once, twice a week. They need to be doing these things constantly. So a lot of my work involves teaching parents how to implement facilitations using NDT techniques. We've already talked about core strengthening. The picture here demonstrates how I work on a baby's core strength, and it's through the use of righting reactions, trunk head righting reactions on a ball. We get them seated on the ball. If you think about it, when you move them, laterally, you're engaging their lateral righting reactions. They have to kind of engage their obliques to kind of keep themselves upright. We move them anterior, posterior. They have to use their trunk extensors, their abdominal muscles to, again, hold themselves in upright. So we figure out lots of fun ways to get their cores working for them. Kinesio taping is another technique I use a ton with my babes if their skin tolerates it. We do a test strip, and if they tolerate it on their skin, I will tape them. A lot of times, I find a lot of our babes, especially those who are looking like they're headed down an ASD road, have some weakness around the core, as we talked about, specifically to trunk extensors. So those back muscles are weak, and I will tape the back extensors and help give them that biofeedback to come up into extension, as opposed to kind of falling forward into flexion. And then there's the treatment of the torticollis and plagiocephaly. which is often indicated. Again, we talked about the asymmetry. So we often see that asymmetry very early on in the form of a torticollis, which then results into plagiocephaly. So again, teaching neck stretches, teaching positioning, teaching counter positioning for plagiocephaly, discussing helmeting for plagiocephaly if that becomes appropriate. So those are the types of things that that we'll do. But I would say most of my work is done through the parents. I am a big teacher. Nothing that I do is rocket science. These families can all take it home and do it. And the more they do it at home, the better results we get with therapy and therapy outcome. All right, toe walking. So interestingly enough, I would say a lot of the children that I treat with autism spectrum disorder, it's later on, it's older kids, around the ages of 5, 7, even as old as 12, who are being referred to me because they're persistent toe walkers. Toe walking is basically a result of a dysfunctional vestibular system in these little guys. It affects their balance, it affects their position sense, and it affects their spatial orientation. And the vestibular dysfunction that these guys demonstrate leads to their postural instability, their impaired gaze, and their gait dysfunction. They're up on their toes, and often they're up on their toes because they need more proprioceptive input or information. So for that reason, this is not a population that I treat by myself. I need an occupational therapist to come in, because if I'm going to get them off their toes, I need to find another way to give them that same level of proprioceptive input to even stand a chance. I'm not going to get them off their toes unless we give them the proprioceptive input they need. The other reason they're up on their tiptoes in many cases is, again, their core weakness. So the tiptoe walking is an attempt to engage all of their extensor muscles to hold them upright because their core is not doing that work for them. So we need to address that as well. Interestingly enough, and I find it's always important here, I'm not sure how many of you are aware of the OAP program, or the Ontario Autism program, and it's a funding program for families of children with autism. OAP does not fund physiotherapy. So these families can access, behavioral interventions, speech language pathology, occupational therapy using their OAP funding. They cannot access physiotherapy using their OAP funding. So they either wait on the public waitlist system or pay out of pocket to access privately. And it is a barrier for these families in a lot of cases. So what do we do with our toe walkers? Again, I talked about I need an OT on board. I need to determine what type of sensory diet, or if they need a weighted vest, what do we need to give them that's going to give them that same degree of proprioceptive input to help get them and keep them off their toes. Core strengthening is a big one. I'm not going to get them off their toes if they have a weak core. They're engaging all of their muscles to hold them upright. So until I work on core strength, I'm never going to get them down. And then there's the issue of regaining the lost dorsiflexion range, right? So these kids come to me with ridiculously tight gastroc soleus Achilles tendon. And so we need to often, depending how much range we've lost, I assessed a young guy recently, and I couldn't get him anywhere out of 35 degrees plantar flexion. He was stuck. So we do night splinting where that's tolerated. Manual stretches are, it's kind of not going to be enough. So night splinting is an option. Often I will pull in a orthopedic surgeon when needed to consult around tendon releases if they're older children. Serial casting with and without Botox is another option, but serial casting can give us some beneficial results. And often they need an AFO that we gradually, so we start them up in a degree of plantar flexion and we slowly bring that heel down as we regain range. But it's a multi-prong approach to get these kids back down. Then we need to strengthen their weak tibialis anterior. So they didn't even know how to engage their ankle dorsiflexors. They've not done it. So this muscle is overstretched and it is weak. And this is where I often use kinesio tape, and in the picture below, I put them into as much dorsiflexion as I can get them into, and I put them in a significant taping application up onto the tibialis anterior, taping them to as much dorsiflexion as I can. So whenever they kind of go to drop that toe, they're feeling the pull of TA to get them back up there. Then there's the gait retraining. So because they're up on their tiptoes, they're always weight shifted anteriorly. So to get them back on their heels, they feel like they're constantly falling backwards. So when they first start to get their heels down, they bend at the hips, and they're bending at the hips because they're used to their weight being that much far forward. So we have to do a whole gait retraining program with these guys to get them back on their heels. They feel unstable when they're back there. They've only been forward their whole lives. So it's a tricky, we're fighting a lot of elements here to get them back down on their heels. And the longer it's gone on, the harder this fight is. Often, if I'm really stuck and the families have the resources, we'll talk about a referral to a developmental ophthalmologist. Their whole vision has changed as a result of their forward weight shift. We talked about the vestibular dysfunction and how it affects eye gaze, and the scope of how the visual system is impacted is beyond me. But suffice it to say that I have seen some amazing results with prism lenses. So kids that I had cannot get down on their heels, we'll send them to a developmental ophthalmologist. They'll put some prism lenses on these kitties, and they just beautifully come down if they have the range to do so. And then it's a matter of keeping them down. So there's a lot of investigative work in these little guys, what's causing them to stay up there. And once we get them down, it's how do we keep them down here now? What's required, what's needed? The sooner we get these kids, the better chance we have of making a difference. So if you see those toe walkers that are staying up there, for 60, 70, 80% of their day, and they're not coming down, refer quickly, please. Okay, and then we can talk about our teens with ASD. So we're noticing changes in the motor system of these guys that last through the lifespan. This is some 2020 research that talks about, these kids have more bradykinesia, the slower movement, the rigidity of their movement, and a trend towards dyskinesia as they age. We're seeing contracture development in our autistic adolescents. And I saw this clinically, a 15-year-old young man, very involved. And he has bilateral elbow flexion contractures because his stimming behavior has his arms in, 90-degree elbow flexion. And when I tried to passively range his elbow, he lacked a good 20 degrees. He's got a flexion contraction. Are we going to resolve that? Is it a goal to resolve that? What are the implications of letting him continue to live with that elbow flexion contracture? It's tricky ones. This family did want to work on the elbow flexion contracture. We put him in a night splint, and they are working on it, but I don't think we'll ever regain full range, and I'm not sure if it's even functional in this case. We also see changes in the gait. Of course we do. We talked about the gait shed differences that we had seen earlier. These don't change if not addressed. So again, a reduced stride length, an increased step width. So they're having a larger base of support. They're taking shorter steps. They're almost walking like someone with impaired balance because their balance is impaired. They don't have great balance, and they don't have great balance because of their core weakness, because of their sensory processing difficulties, because of their impaired vestibular systems. So their motor system is highly impacted. And we see reduced range of motion at the ankle and knee with increased hip flexion, right? And we just talked about all of the possible reasons why that might be the case, especially at the ankle with our toe walkers. So gait, it doesn't look at in these guys, it looks different, and it is impaired, and it affects their ability to perform motor tasks down the road. I often get a lot of teens with ASD who are referred to me because they have a goal of bike riding. And it is a difficult goal, and the parents want them to ride a two-wheel bike, and often I have to, so is bike riding important, or is riding a two-wheel bike important? Because we can get them a specialized trike, but they can get out and move themselves through space and have a lot of fun on relatively quickly. To ride a two-wheel bike, that is going to be a much longer process and for a lot of these kids, a terrifying prospect. They feel very unbalanced. They have no direct contact with the solid ground beneath them. And with gravitational insecurity that they demonstrate, this is not a comfortable place for them to be. So again, it's determining what's the parent's goal versus what's the adolescent's goal in terms of bike riding. Any questions? I'm just gonna throw it out there before I keep going. I could talk for days. I'm sure you figured that out by now. Okay, so when to refer to a physiotherapist. And these are just a few things that's specific to autism spectrum disorder and what you're seeing in that population. And I would suggest any motor delay, not even delay, but any quality issues that you're seeing in terms of use of left and right side of the body. And we talked about that in the next point, you know, significant asymmetry in their motor development. And again, early intervention is always better. I'm quite happy to assess a child and tell the family that, no, they look okay, actually, you're doing great. I would much rather that as opposed to, well, let's wait and see how maybe this will develop, maybe this will come around. And then things actually, that gap widens between what they should be doing and what they are doing. So refer as early as the parent is willing to go there. Yeah, and normalize that refer, absolutely. When you see a lack of transitional skills in the developmental course, specifically rolling, if they're not rolling, refer. If they're not pushing themselves up to sitting, if they're not pulling to standing, if they're not transitioning from sitting down to lying, all of those transitional skills and the lack thereof are concerning and tell us that something's going on. This child is stable in a position, but they can't get out of that position. And parents often compensate by just moving them from one position to another, but they never learn how to do it on their own. And that's a concern. Bum scooting, please refer your bum scooters. This is not a typical way to move through space. And these children, if it is the way they do move through space, will have fine motor difficulties down the road. So if we get them early, we can actually work on strengthening the core, strengthening the shoulder girdles, to kind of prevent those fine motor and core weaknesses that can come later in life. Poor tolerance to prone, especially when we see a plagiocephaly developing. Again, what's going on? Why are they not tolerating weight bearing on their upper extremities? We had talked about how that can be. It is something, one of the commonalities that we see in those infants at risk of ASD. Prone is, you know, I tell parents, if you only do one thing a day, put your child on their tummy. And the goal in early infancy is 60 minutes a day. Obviously not a one shot, but 10 minutes here, 5 minutes there, 20 minutes here. Prone is the biggest bang for their buck. It's like you guys doing plank. If you just do one activity every day for your own physical fitness, plank, do plank. Very similar concept. It hits so many muscle groups. Biggest bang for our buck for infants is prone. And it helps with skull shape, and it helps with vision, and it helps with core, and it helps with shoulder girdle strengthening. So many benefits to prone. So if they're not in prone, refer to your friendly physio to help mom, dad, caregiver develop strategies to increase tolerance to prone. Toe walking. So if they're not coming down on their flat feet early in the standing, you know, they can go up on toes. It's absolutely fine. And when children are learning how to stand, they're turning on all their muscles. So often we see them go up on toes early in that developmental course when they're learning to stand. That's okay too. That's a typical response. What we want to see is as they, you know, selectively turn muscles off that they don't need on and upright, the heels come down. Again, they're going to get excited. Often when kids get excited, we see them go up on their toes. Totally developmentally appropriate. But again, are they coming down? Are they staying up on their toes? That's where we have a concern. We need to see them come down on their heels. We need to see that ability to come down on their heels. And again, refer to physio. Often we see referrals for speech and OT, but based on all of the motor dysfunction that I've just talked about in children with ASD, I would suggest that physiotherapy needs to be a part of that diagnostic group. And again, we're going to talk about hitting priorities, you know, what the priorities are as we kind of go down the road. I'm just looking at this question from Becky. What is happening in the brain with ASD that leads to the physical impairments? Oh, Becky, there's like reams of information written about the theories behind this. And a lot of it right now is still theoretical. But we are seeing less development of the corpus callosum. In other words, we're not getting as much connection or connectivity between the right and left sides of the brain. That's one thing that we know about. I've read about cerebellar impairments, so that affects balance, vestibular system. And there's still, the jury is still out on, what came first, the chicken or the egg, right? So are these things happening in the brain that are leading to this, to what we're seeing physically? Or is the physical manifestation of what we're seeing changing the hardwiring of the brain? And I can't answer that question. It's a great question. And I'm happy to send you some resources because there's some literature out there on that topic. But at the end of the day, and I often get that from parents, even when we don't have a diagnosis, well, why is my child doing this? Why is my child doing this? And I often say, I don't have an answer to that, but I know that I treat what I see. So this is what I'm seeing right now. So this is what we're going to address. And this is what we're going to try and treat. I can't necessarily directly change the brain, but I know that by doing my NDT facilitations, I can create new motor pathways in your child's brain. And that's what we're going to try and do. Do we have as much success in creating those new motor pathways in an ASD brain? I'm not really sure. It's a very good question. But I'm going under the assumption that it is plastic, as all of our brains are. And they do, we know this through other interventions, that neuroplasticity is possible. So we're going to bank on that, and we're going to continue to expose to normal development and typical movement patterns. I hope that answered your question a little bit, Becky. But like I said, I'm happy to send some resources your way. There's a lot out there. So we talk about the 3 levels of autism spectrum disorder, where level 1 is kind of the most mild version, and level 3 is the most extreme of the 3. So level 1, and these are the ones that sometimes don't get diagnosed as quickly because parents do such a great job of compensating in a lot of cases. Sometimes level 1s don't get picked up until they hit school. So they have trouble understanding and following social rules. They can be rigid or inflexible in their behavior, stress during transitions, and they definitely need therapy and they need help. But again, parents can be so great at compensating when you think about what you see there, that they often don't get picked up. Are there motor issues with these kids as well? 100%. These kids do have balance deficits. They have motor planning deficits, they have coordination deficits. So we do see physical manifestations, but again, not as extreme. So sometimes I will never see these guys until, they start to ride a bike and they can't quite get it. And then they'll refer to physiotherapy, but they didn't need a whole lot of help walking. They might've been late walkers, walked at 17, 18 months, but that's your level 1s. Your level 3s, severe deficits with communication. Often they're nonverbal, repetitive behaviors, stimming, as they call it. So rocking, spinning, often they'll be the flappers, so they get the visual stimulation. Extreme distress when it comes to switching tasks or transitioning. Often need one-on-one use of educational assistant support. Often need alternative and augmentative communication support. These are the guys with, that develop the elbow flexion contractures from their stimming behaviors. These are the guys that have wide-based gait, that, motor patterns are severely impacted, severely affected. Often these are our toe walkers. So very high levels of support in our level 3, and level 2 is kind of in between. And because it's a spectrum, there's no, this is 1, this is 2, this is 3, they're anywhere along the spectrum. But these guys have atypical social behavior. They can't read social cues very well. They don't get sarcasm very well. Jokes can be tricky. Very high interest in specific topics, almost become hyper-focused. Our clinic in Prairie Sound, it's so funny, it's right behind the train tracks, and for some reason children with autism have no thing for trains, and if a train goes by out the window, we've lost them for the whole therapy session pretty much. noticeable distress when faced with change, but can be taught strategies on how to manage and how to transition more smoothly. And they may also need some significant accommodations at school, specifically around higher academic tasks and social skills. Social is a consistent difficulty for this population, as we know. Physiotherapy involvement in all the 3 levels, it really depends. I would argue that we can benefit wherever there's a motor dysfunction, and we know there's motor dysfunction in ASD. However, we have to look at what the priority is for the family. So if, for example, the family really just wants to be able to take their child out to the grocery store, and the behaviors are impacting that so greatly, I'm not the priority at that stage of the game. That priority is how to manage their sensory system, how to manage maybe their communication so that they can tell you when they're getting overstimulated. So it's a matter of what's the biggest priority here. These families have a lot to deal with, and often I'm far down the road in priorities, and that's absolutely okay. They need to determine where they're going to put their energy, where they're going to put their child's energy at that particular time. The other thing is, the children gets older, we need to consider the priorities of the child. So I will often get calls from parents that I need you to work on this. And then I go and I see the child at school, or they come into the clinic, and explain that this is what they've been referred for, and mom or dad would like to address this, and this is not a priority for this child. They could care less, whether it's bike riding or walking on their heels, for example, getting them down off their toes, not a priority for them. So it becomes tricky at that point in time, because I don't know if you've all had a lot of experience with teens, but if it's not a priority for them, you're fighting a losing battle, and I cannot do the work to make these things happen. I need buy-in from the kids, from the adolescents specifically. So if that's not there, there's not a whole lot we can do except wait until it is a priority. And this does happen. I had a child, again, parents, it was a gait issue. Parents wanted to work on her gait. They didn't like her gait. And this teen was like, I'm fine with how I walk. It doesn't bother me. No, thank you. Okay. I saw this teen years later, she's a female, and it wasn't until she was getting married and she wanted to wear heels at her wedding, and she didn't have the balance or the ability to walk in heels. And she went to see an adult physio and worked on it so that she could walk down the aisle in heels. So until it's a priority for the client, it's kind of not a priority. Parents don't like to hear that. I just wanted to throw this in there because in our community in Parry Sound, I do work with a lot of Indigenous children. And Autism Ontario has kind of put out a bit of a research highlight on autism and Indigenous individuals and the differences that these individuals and families face in terms of not having the same access to therapy, these children spending more time in our child welfare system. And why is that? Acknowledging our place of privilege within the system and how we can be very respectful of the cultures. And when we're working with these children, bringing culture into our treatment, which I'm very keen to do. So for example, I work on Wissahickon First Nation, I work on Magnetawan First Nation and Shawanaga, and we do a lot of work outside. We're working on balance. Okay, we're going to find a trail, Rudy, we're going to go through the forest, we're going to deal with roots and rocks, and we're going to do it in a very different way. We're going to get out of the clinic. I was stretching one young girl at Wissahickon last week, and I did it while she was sitting in a tree, like climbed up the tree, and she's sitting there, and her foot is literally at my face, and we're stretching her ankles out there. So we really need to meet our children where they are. We really need to understand the extra barriers that are in place for our Indigenous children and families as well. So, Autism Ontario has some great information out there. It's one of my sources that I go to regularly when I'm working with these populations, and I would suggest you guys have a look as well when you have time, which I'm sure that's scarce. So I want to thank you for taking your lunch break to come and listen to me today. I did leave some extra times for questions, conversation. I also provided both my email addresses on there as well as my cell number. If you do have any questions, not only specific to children with autism, but children and physiotherapy in general. In Perry Sound, I find as a pediatric physiotherapist, I very much have to be a generalist. So I do a little bit of everything when it comes to children. Yeah, I just noticed another question from Becky. At what age is autism typically diagnosed, and does this facilitate early intervention? Diagnosis is actually later than when we see signs. And again, I see signs. I'm seeing children often because they're late walkers or not walking. And I see kids come in to see me, and I can pretty much, they look like they're on the spectrum, but they don't have a diagnosis, and we don't need a diagnosis to treat them and see what we have. But I'd say diagnosis, it's getting earlier. Early diagnosis right now, I would say, is between the ages of 2 and 3. We are having kids obviously diagnosed much later, but between 2 and 3 is not bad. I think the earliest I've ever seen is maybe around 18 months. But a big part of diagnosis is obviously waiting for the specialist who needs to come in and make that diagnosis. So, I work in a multidisciplinary team, speech, occupational therapy, physio, and we can know a child has autism long before that diagnosis comes. We can't share that information, but we're working with them with the assumption that that diagnosis is coming. Any other questions? Well, you have my information. If anything comes up, and Kathy knows how to reach me as well. And again, I thank you for sharing your lunch break with me.
Okay, well, anyone's thinking of any last minute questions, I'll just let everybody know that October 26th, we have Dr. Noomberry, who's going to be coming and presenting to our team on prostate cancer pathology and diagnosis. So that'll be noon on October 26th. And I'll hand it back to anyone who may have a last minute question.
And Kathy and I were chatting before you guys came in on, possible future topics, because as I mentioned at the beginning, I'm completing my training in psychotherapy, and we see lots of very specific mental health challenges with our adolescents with autism spectrum disorder as well. So that's a whole other fascinating topic of conversation that maybe might be of interest at a later date. Thanks for the invitation, Kathy. It was my pleasure to be here today.
Okay, thank you so much, Lisa, for coming and presenting. I know I certainly learned a lot, but I knew nothing about the physiotherapy side of things, let alone autism. So thank you. I really learned a lot today.
Awesome. Thank you, guys.
Thank you.
My pleasure. Bye, everyone.
Bye.